All right, dear doctors, thank you so much for joining this session. This is your mentor, Dr. Shahriar, going to start. I hope I'm visible and is it okay, like everyone doing well with all these things? Great. Yeah. Let's just wait for 1-2 minutes before our all the other doctors will be joining, and then I'll be guiding you, I mean, throughout. So do not worry at all. Everything this matters actually. I'll be definitely guiding you through the end. It will be a 3 hour session just for more information. So let's just wait 1-2 minutes last before like others will be joining in. Thank you. Okay, one thing we can do in the beginning. No, we haven't started, but just about to start actually. So in the beginning, just let me know from which city or country you are attending this particular session actually. In terms of question answer, we'll be making a session later after the class, so I'll be opening a inquiry zone later after the session. So in that time, feel free to ask me questions. Actually, thank you. So in the beginning of the class, I'd like to ask all of you. Just remind today is a respiratory. So I'll be guiding you what to study, how to study, and all these things. The beginning question is actually from which city or country you are attending this particular session. And also let me know if I'm visible and everything is loud and clear. Uh, Often in the, you know, army official, they use this term like loud and clear. Yeah, great. Okay, so everything looks okay, actually. That is excellent. Yeah, and I think most doctors came from India, Bangladesh, Pakistan, Sri Lanka, Nepal. Then, of course, many will be attending from um, Australia, of course, like from many different countries, Australia, New Zealand. Even I can see a lot of, Fiji Island doctors over the time, actually. Uh, about AMC, I have been a tutor for uh, 9 years. I think it's my ninth year. And under the guidance, I think Alhamdulillah, it's almost more than 1,800 has passed actually, so it's a very big landmark. You can also check our pages for reviews and this, that. Apart from that thing, the more important, we try to guide properly in terms of whoever joining. You will get to learn like good processes of study, what is needed, and most updated course you're going to join. Actually, that's one of the thing. I mean, anyone can come up with some teaching skill can make a course, but while we have one thing is a very very high passing rate. It's like over 90%. It's been always actually. It used to be like more than 95, but over the time MC has been getting difficult, and keeping that level is difficult. But we try our best. The reason, like, we keep hard working, our student keep hard working. I will be pressurizing you a lot. I'm not sure that sounds very good to you. I mean, at this point of time, sometimes people don't like. I've been trying to push a lot actually, especially every week there will be exams and this, that. But I think some of you will be agreed that after we left the MBBS level, no one really to push actually for study courses and all these things. So it works for a lot of people, but some of your privacy might be hampered because of this, because I'll be pushing you a lot throughout this course actually. This is a course mostly for the beginners in MC, I mean, whoever being a doctor and maybe in different field. So I'll be guiding you with the syllabus as well. Yes, what we will be providing and this, that I'll be talking very soon. So don't, no worries on that one. And those of you just now joined, introducing myself, this is Dr. Shahriar. I've been an MC tutor for last 9 years actually. I've been going through MC earlier in my life, and then of course kept taking classes. Started with publishing books, then start taking MC classes after finishing my MC, and that is how it's get started. And it kept getting bigger and bigger with time, but and I keep updated. I mean, every month there is a thing. My students always go for exam every month, 30, 35. Some months is beyond 50. Even end of the year, it's almost like, 100 per month, like, especially in November's. So, still we have to take classes every month uh, during exam time. So that's how I remain updated actually. Great. Will we talk about books and this, that? Starting, and if anyone joined late, please update yourself in terms of like from which city or country you're attending this particular session. And we'll be later talking about getting study partners, how you can get. So this is an MC course. I mean, it's a first class and trial class. I'd like to thank you all of you for joining this MC part one course. This is a part one course. MC is of two parts, MC one and MC two. And this is the official MC website. This is the official MC website, not our website. Our website is mdonlinecoaching.com, but AMC website is this one. Actually, you can get all the necessary information. This is a 5 months course. We have a 3 months course that's more advanced level, but this is a 5 months course, by the way. Great. And yes, we'll be talking a lot of things about the exam. It's a bit expensive. You can always check the website for updated, um, exam fees. It's a bit expensive, but when you will be a doctor, you will be earning a lot actually. So that's most important. All right, here we go. Like that's like the thing. And of course, the huge number has passed from this academy actually with a 92% till this passing. It's over 90, it's been always actually great. And after that, I mean, we'll be guiding you. This is our website. Actually, you can also check about courses, 5 months and 3 months. And we're streaming live, and so there will be live classes with us with weekly mocks. So there'll be two live classes, and there'll be one overview. Overview is not a live, but I will guide you through the overview. We know what topic we're going to start. And today is the first class, so we didn't have that overview thing. But normally Sunday and Thursday there will be 3-hour classes. Okay, so and that is how you will go on, and then there will be weekly mock. This is how it continues for 5 months. Is it loud and clear, guys? Actually, so it's always been live class, and we keep guiding you through the live classes, and there'll be weekly mocks, and that is how it goes. After classes, we upload the recording actually. All right. So this is how it works actually. Great. All right. Okay, so as we progresses, we take classes by Zoom. Yeah, so it's been, amazing supports from the students. We also ranked one naturally. I mean, didn't have to do anything pay. I mean, it came up. Yeah, lot of people, lot of doctors said, it's a good course actually, and they got a lot of hope on it actually. All right. So that's great, actually. I'll be demonstrating with a lot of things, actually. And I hope so you are in our this particular group, share SMC guideline group. Maybe this is how you get to know about us, or maybe through my YouTube channel, maybe you get to know about us. You can save this number, like, after class, you can text me. It comes to me directly or to my team. So this is the number. Maybe you can take a screenshot later if you want to contact, or you can contact through me, my Facebook Messenger, because after classes, a lot of question comes out. I know. Great. Okay, so that is how it goes. Actually, I'll give you a demonstration. How notes and things looks like. So do not worry about that one actually. And yeah, this is my YouTube channel. You will find this channel name. This is how you can find me. There's over 200 videos given. A lot of sample classes and things are given. So here's the thing. Are you the next doctors, like, who will be already into the system? Yeah, a good number of jobs are available, so it's still of job in Australia, particularly after COVID. Like, in Australia's, like, they've opened a lot actually, especially after the COVID season actually. All right. Yes. Yeah, class we uploaded after 24 hours. Yeah, if I'm taking class now, usually next day after taking rest, I upload the recording. Thank you, my dear. All right. Already more than 1,100 is already working and passed already 1,800, and many are under the process. Normally, the job thing started in the month of February. The first half of the year, there is a job circular. And then the second half of the year, in the month of June, there's another job circular. We call it often, I'll type the name. Its name is JMO campaigning. Okay. Yeah, because all you need job at the end. So you can type this name, you can search later on that one. Great. Yeah. If you don't pass, can you get a different? Of course not, actually, but you will get to attend our course again free of cost, actually. All right. That's the thing. Right. Okay. We have question though, actually. All right. Yeah, yeah. We don't charge. If anyone get failed, you will be. welcome back to the course because that's a responsibility. Many already attending it in that way. All right. Yeah. Thanks for asking that one, by the way. Yeah. Very rare academic gets that opportunity. We keep giving that one all the time. Okay. Anyone have our class routine, by the way? Anyone is having our class routine? I take the screen. Anyone is having our class routine? No? Okay. If not, like, let me show you in a second in our screen. All right. This is how it looks like. Let me know if it's visible to you. Okay, so you can see this 25th of May. Yes, a lot of people. All right. Yeah, make sure you have a good network during the class. Zoom needs very less, uh, internet, honestly speaking, unless you have a network issues or storm going on, which is different. Otherwise, supposed to be well. Even with the mobile data, you're supposed to attend. By the way, I hope so you're in a laptop device because we often recommend coming, sitting like this and using a laptop or PC for taking the classes. Okay. Also keeping some data in the mobile. Some cases, if there is an issue or something, you can quickly come to live by mobile as well. While working, maybe you were in the job. If you got stuck, you can come with the mobile, but normally we recommend to come to classes with a laptop or PC. All right. I hope this is clear. I will take much time here. Now you can see, and this will also give you a clear idea about the syllabus in any way. You can see we're starting from the 20th of May. We're starting with the medicine classes. Please listen carefully, this particular part. All right, great. Now you can see that one, like the medicine is this, medicine starting with respiratory, GIT, cardio, goes on, renal, rheumatology, endocrine, and every classes has a theory and a question solving session and a mock. Okay. Did you check this one? Guys, please, if you're following me, please comment as well. It's loud and clear. Question answer will be taking later. Okay. If you are in a job all the time, I think maybe this batch is not right for you. In that case, we have a Netflix type course. You can come there actually in that case. Okay. We'll be talking about that one later. No worries. Okay. My dear, initially, I recommend you to just listen. I mean, then of course you'll get full idea. Your all the necessary questions will be answered. So we'll start with the medicine. So let me give you an idea about the syllabus. Like it's all the clinical subjects. I repeat, it's all the clinical subjects. It's not like the typical anatomy, physiology, biochemistry. That's not the syllabus of MC. It's all clinical subjects. So you see medicine under medicine, so you can see dates are given. So respiratory, renal, rheumato, endo, like neuro. Then we'll start the pediatric theory one, theory two. We do have also notes in our note section, which I'll be demonstrating very shortly. And apart from that, the surgery and general surgery, emergency surgery medicine is a combined class. Mostly it's like count it as a surgery class. Then orthopedic INT, and all of those also have theory and a recall class at the same time. Okay, is this thing is clear to everyone? Just Sunday is our theory class, which we are also taking today, but I'm trying to give you some demonstration. And Thursday will be our question solving class on the same system. Okay, it took us like more time to organize those things and blend and collect the last kind of 2 years of the systems and add some of the classics. For example, I cannot delete a question like pneumothorax or a asthma related, even though if it does not tested in last 6 months, but I cannot delete a question from asthma and pneumothorax because it's been classic question and there are some pattern of question they keep testing all the time. Okay, so you don't know in every month which one they will put, but there is a certain pattern they always keep giving. So when we make files, so we need to keep it in mind which are the classic and very new one. Example, during the COVID days, we had to add the COVID question. Now the COVID question disappeared again. So you understand, guys? I mean, some of the question comes as a necessity or new research in AMC, which we will update you time to time. All right, great. All right. Now, after the surgery, then we'll be proceeding into gynae and ops. There'll be, extensive session on the gynae and the ops as well. A lot of people forget gynae ops, right? I mean, after some time. And of course, the psychiatry, classic psychiatry. I mean, it's not superficial, it's quite a deep psychiatry, which you will learn here actually. And after this, there'll be ethical session. And as I small mocks continues, and then there will be some special videos which we'll be sharing with you, including C fundoscopy, ECG, CTG, radiologies, and then from this last sections, these are special before exam. I mean, there's some special like one fundoscopy always comes, one ECG always comes, one contraceptive always comes, some driving screening, this type of things keep coming in the exam. So from those, you need to check them just after the class, and just after the course and before the exam. It's also very important. And we'll be also taking a big mock actually as like a computerized at the same time. Actually, we need to put you under that pressure, like main exam, so that you go through the same experience, and it's very, very important. Can you really tolerate actually? So something new will be coming up always. Something new will be always coming up actually. All right. Again, this is the number you have. Like you can WhatsApp, or if you know my Facebook Messenger, you can also inbox there. Actually, me or my team, anyone probably will get back to you actually. Okay. Clear about the syllabus, guys? It's all clinical subject. If anyone joined it, medicine, then there will be surgery, then pediatrics, then surgery, general surgery, systematic surgeries like INT ortho and gynae obs, then psychiatry, and then ethics. And there are some miscellaneous. Please comment in the comment section. Yeah, if that's okay. Do I need to raise the volume, or is it okay? I suppose it's okay. I think maybe the doctor who is attending, yeah, I think maybe having low volume. Maybe you can use a headphone, turn on your volume. Yeah, I think it's okay. Yeah, we have been professional taking classes all the time. So I believe it is okay. Yes. Yeah, I think it's okay. Just check. Yeah, I think, see, mobile user, see this one, mobile user. So your mobile user, I don't know how you're using it, but I think you should try a laptop device. You might, get the clear volume in that case. Yes. So mobile user, I mean, keep it to yourself. If you cannot listen well, maybe you're trying to listen with a directly. So try use a headphone like this. Okay. All I say it's useful. Yes. Great. And I'm sitting in a very closed room actually. It's a sound protected room. So I'm quite sure the sound goes very nicely because I've been professional. I've been taking the 62 batch. So I think you can get it actually. All right. Okay. For now, I think clear about the syllabus. Some else other things to be told now. Let me tell you about a little bit about our SMA notes actually. Okay. All right. So before going into that one, I mean, we do have a extensive notes. But before getting into notes, I mean, let me tell you a little bit brief about how to study for AMC. Do you want me to tell that one how to study? I mean, that's my job, how to study for AMC. Okay, so get it right in that way. I mean, this is one thing, rule of five. So what is the rule of five? 5 hours a day. I hope you're writing 5 hours a day, 5 days, 5 days a week, and for 5 months. So 5 months is our signature course. I take all the classes. Some doctors, do you take all the classes? Of course, I do take all the classes in 5 months course. Now, how to study AMC? Now, this is the thing, like Sunday is our theory class. We'll get all the idea what to study, what not to study. See, example, if it's a respiratory system, I can take like almost 1 month class because I'm a respiratory physician. So I can take a month class on respiratory system. But the question is, do you need that information to pass the exam? All right. Do you need that uh, all, like a MD, FCPS, this kind of information to pass MC exam? Not really. So, so we will go exam specific. Okay, guys. So we'll go exam specific. Do you agree, guys? Like, we should study more like exam specific because at the end, your syllabus is already very big, right? Your syllabus is already extremely big. Now, if I make it even more bigger for you, so it will be like you will be in a terrible situation while revising, actually. So, what is easy in life, like, as a tutor, from tutor's prospect, to make a very big slide, is it more easy or coincising, which one is easy? Making big PowerPoint slide is more easier to compress those things, and which one exactly important for the exam, That is more important actually. Okay. So that's how we are here actually to guide you. All right. So study Sunday, you will get all the things. Like today is a Sunday, we'll be starting the respiratory. I'll guiding you what to study. And of course, I will brief all of them actually. So today's class would be a little bit longer, like a 3 hour, maybe 3 hour, 15 minutes, because initially I'm demonstrating a little bit. Now, Thursday, it will be a recall course. Now, some people don't understand what is recall. Recall means question solving. Question we collected from our own students actually. Okay, are also some of the forums out there where people after their exam they tell what came in the exam. These were the topic, these were they asked. This is how we collect it, then we try to complete it a little bit. That is how we brought it in the classes. Now next Thursday class, which is also open for all of you, you can come and see that class as well. So Sunday class, all the theory necessary, I'll be teaching from the John Murtagh. So all you need your John Murtagh with you. I'll be helping you marking the important points, like same like this. You'll take a marker like this and important things you will highlight. Only thing I'll be telling you, you need to highlight actually for AMC. Okay, because those things will be mostly tested in the exam. So Sunday, that is for the theory, John Murtagh marking, and the necessary things to learn. Thursdays will be a discussion class, more like question recalls and question discussions and all these things actually. About the question bank things, after 2, 3, 4 classes going, then we'll be talking about the question banks. But in the market, there are two question banks available, 2 or 3 question banks. Like there is a AMC Q Bank, there is Amedex Q Bank, and there's another one, MPlus Q Bank. Anyone you can pick up actually. That's how it works actually. Some people ask me standard. I think there's nothing like standard. Anyone, if you pick up and revise it again and again, because from this question banks, you don't get to see much questions coming in the exam, but similar topics you'll get to see. From the recall rather than are more important. So simultaneously, we recommend you to solve recall at the same time do at least one standard question banks very well from starting to end actually. Okay, everyone clear? Everyone clear about that one? All right. As I mentioned, three names are given: Amedex Question Bank and AMCQ Bank, and then the MPlus one actually. So these are the three. Any three. I'm a very big name in MCFIL. I don't take any one name particularly. It might look biasness in that case actually. So that's one of the thing actually. Okay, we'll talk about question bank later. Okay, it's not a today's cup of tea actually because it's a trial class. So those will be our student. I'll be talking more about the question bank later. Okay, we have a lot of things to discuss. Okay, coming with the things now, it's about the books actually. What are the books you will need to follow? So there's so many videos in my YouTube. Have you seen any of them about the books actually? Now, can you mention some books which I have already mentioned in YouTube channel? A lot of books you're supposed to know already. Okay. Now, of course, this was everyone know John Murtagh. John Murtagh. This is the Murtagh's. Okay, Murtagh's general practice. Some people don't get confused which Murtagh. Why I'm searching this 2, 3 Murtaghs are coming. John Murtagh's general practice. Okay, get it right. Not companion, not like a counseling book or some. John Murtagh has 3, 4 books, but John Murtagh's general practice. Okay, that is the book you are looking for. Then comes another official book. I'm talking about initially some of the official books like the AMC Handbook, very old book. Now no new edition for a long time. Okay. Even though Kaplan is a like kind of book related to USMLE, but sometimes we use the Kaplan, the psychiatry and this that. Okay. Sometimes we do use Kaplan psychiatry. But even though we have SMA note, we do follow that one. MC Handbook, no new edition. That is correct. So John Murtagh, MC Handbook, Kaplan, the psychiatry. Now coming to the other books, there's some more other books. John Murtagh is currently 8th edition is ongoing actually. Great. All right. So these are the books like that is mandatory. Okay. Initially mandatory. Okay. Then very, very important, like the notes. So many people like notes actually, like things which is like bullet points, things which is more like compiled. So most of our students, along with these books, they follow SMA notes. Is it clear, everyone? SMA notes actually. This is another version of the theory classes and vastly being used actually. Now, how it looks like. You see, alphabetically, if we go, uh, I mean, those of you who have joined, I think I have send you the materials, I think. Already, I think 150 subscribed already. So I think I have sent the notes and to those, I think, subscribed today. Maybe they didn't get it. Probably I'll send them tomorrow. That's the update. Now, some people's notes looks like this. It's just because they're changing in the. So which view do you think it's more nice? This one or this one? What do you think? Okay. This view or this view? So this one is a list view. This one is a thumbnail view. Okay, so please mention in comment section. This is a learning process, guys, because you all will be using Google Drive, not only for my classes, in future as well. So some of you might be not familiar with using Google Drive. Okay, so this is a list view. So I can check the alphabets very easily. So if your Google Drive is like this, open a laptop next time and click the list view. Now, this is how it looks like. So initially, E for ethics is there, G for gyne is there. And what we need initially, we start what? With medicine. So medicine, we will go alphabetically wise. So say example, initially, medicine and respiratory. So we'll find out medicine and where is respiratory. Okay, now here is respiratory. You can see with the medicine, respiratory asthma, respiratory pneumonia, bronchiectasis, even COVID, lung abscess, pancoast, pneumothorax, many other things, many other things. Let's click one of them, how it looks like. We'll come back here eventually. We'll come back here definitely eventually. So, for example, this is pneumothorax, and these are the relevant thing which is much needed for the AMC exam. All right. So these are the things, and I'll be guiding you. These are the all essential things needed for AMC. This is how I tried to keep things easy actually. All right. Great. As I said, I'm not answering the inquiries now because we're in the class zone. So at the end, I'll be opening an inquiry zone. I'll be answering few things. All right, guys. Great. Now this I'm demonstrating right now. Aim for medicine, aim and respiratory. It's your target. Is it clear so far now, guys? Guys, again, I'm telling I'm not answering anything right now in the inboxes. I'm just giving a demonstration right now. Is it clear so far how to go initially? Initially, aim for medicine, go into the system you are currently studying with us. Okay, so this is the thing. So we're talking about the books. Books is necessary. Why? For the theory classes, right? Books is necessary for what? Books are necessary for the theory classes. So for the theory classes, John Murtagh, AMC Handbook, Kaplan Psychiatry, all these things. But mainstay is what? This is your mainstay. I hope that's clear. So notes to follow, you'll get a clear idea along with classes. Then the John Murtagh to follow. John Murtagh still is very essential because it's updated. Why John Murtagh important? It is updated. Great. Now, so there's some other books like, can you mention some other book name, guys? Like for gynae what do you study? Any books for gynae anyone remembers? Okay. For the gynae Linian Jones. Kaplan is okay, or you can say slash Kaplan, but lenient. Most of our students follow the SMA note. Okay, especially obstetric is not given in the Linian Jones or Kaplan or in John Murtagh. Okay, so eventually they follow the note, especially obstetrics is definitely. Yeah, another one, we are just about to tell is here. Let's go here, especially two more books for medicine if you can open. So when I used to study, I used to keep 2 3 books open. That time I didn't have a seminars. So because I went through FCPS, so Davidson was in my nails that time actually. So Davidson's medicine I used to keep open. So still it's a good book, nice crunchy boxes. If you know well Davidson, you can keep it open actually. Always it will give you a extra idea. Then there is another book, MTB. Do you know what is MTB? Master the board. Even though a new assembly book, but quite a crunchy book. Okay. Some cases you can follow Oxford surgery. Some cases you can follow Oxford surgery. And there's another one, Tizendra. This is another surgery. Yes, you can put like Datta name. That's also fine actually. Okay, you can put the name of the Datta. I mean, our subcontinent doctors, because we have a very vast, big of number of doctors. If you are familiar with that one, it is fine. But as I said, mainstay, people will follow our notes, and then it's given in the reference, even which book to follow there actually. Clear, guys? So you can also Kaplan or Datta or LLJ for gynae again. Yes. There is 100 case of medical ethics. Okay, very small book from the Kaplan series. Very nice for the ethics actually. Clear guys? Very nice for the ethics. Okay. Someone is looking for a study partner. If you try mentioning these things right now, I might, put you out of the class because now it's not time to discuss those. You need to focus, into the uh, things are going on. It also disturbs others. Okay. So please do not do those kind of things now. Yes. Is my voice and visuals and loud and clear? One more time. I hope it's not distracting. Okay. All right. So again, a lot of book of list of books. I'll be demonstrating these things again and again. A lot of YouTube videos are given on the books. There's some reference websites. One of them is very, very popular. Can you mention one too? Yes. So there are things like RACGP, then RCH guideline, rank course. Okay, so these are like quite nice websites. Medscape. Okay, so sometimes some topics will not find or new topics will not find in the books. So in those cases, we'll look forward to that. Look forward to that. Great. So great. I hope these are clear to all of you. All right. I hope you guys are not tired. Initial day, it takes a little bit time. Okay. I just take care of the screen. Just get into respiratory, right, guys? And I've gone through that enough. And here we go. Let me share the respiratory. We don't want to waste more time before getting into there. Okay. Is my screen is clear? You are supposed to see a blue color screen. Please mention in the comment section. You're supposed to see a blue color screen. Oh, wonderful. Okay. Again, if those of you joined later, welcome. This is Dr. Shahriar. I've been a teacher for 9 years, and under my guidance is 1,800 doctor passed. I'm sure you'll be the next person we're looking for to work in Australia, actually. All right, so we have gone through these particular things. Now, for this session, like a Sunday session, you need to have your John Murtagh. If you don't have a John Murtagh, order one. All right, so this is the information actually. And also use a laptop device, use a headphone like this. Okay, and we can do an interaction by the Zoom chat box and this, that. Okay, so here's the thing during the Sunday live classes, use laptop, attend live, watch class instruction, how to, today we're getting it. Open again, John Murtagh, keep participating in the Zoom actually. Links, of course, important. Like some people keep asking us, where is Zoom link? Usually we provide Zoom link 1 hour prior to the class. I hope that's clear. And there's a Sunday class live coming up as well. The same instruction is laptop attend live, watch class instruction, how to follow the class on the recall day and keep participating again in the Zoom. I'll show you questions and you'll be participating on the Thursday as well. Mock, every Sunday after class, we'll be providing the mocks actually. We'll show you how to do that actually, not now actually. So books, recalls, key points, and you can keep a diary to take small notes actually. Now, here is important thing before we are entering and jumped into John Murtagh. This is the thing, we're looking forward. This is the particular topic, John Murtagh topic that been tested very regular interval in AMC, starting with the asthma, COPD, bronchiectasis. In short, you can remember them A, B, C. You can see the A for asthma, B for bronchiectasis, C for COPD, and these are obstructive lung disease. So these are the page number in John Murtagh, which I'm going to teach you shortly in next 5 minutes. So these are the topics, and we'll turn on the page actually. And of course, then there will be lung cancer, pleural cancer, mesothelioma, the next page. We'll go get back to all these topics again and again. So mesothelioma 397, sarcoidosis 463, pneumonia 393, latent tuberculosis. Typical pulmonary comes very less unless they give someone is traveling and came back with the tuberculosis as a pulmonary, but mostly popular in exam is a latent tuberculosis. Okay, now here you see certain things. This is a John Murtagh handbook, and handbook is not given system wise. So what we did is cut through it And we figured out what are the questions related to respiratory in handbook. These are the questions related to respiratory from the handbook. Okay. So maybe you can take a screenshot of that one, or maybe you can post that one later. Okay. So this is the questions. This is the pay book. I think you understand, right? Which book is this? This is the handbook. So if you study with me, it will be easy for you to. You don't have to read the whole book separately and becoming a burden on you. Rather than you can go with me. After starting the topic, I will teach you. Then just go through it. It will be like a crystal clear for you. It will be very easy for you if you just go through the topics, theory classes with us and the recall classes. And after you hit this one, it will be very easy for you. Great. All right. Okay. Time to start the John Murtagh. I'm giving you a few minutes of time if you can bring your John Murtagh, if you can. Okay, guys. I'm taking a few seconds so that you guys can bring your own John Murtagh. Yeah, if you don't have a hard copy, I mean, you need to buy a hard copy in future. Okay, very, very important that our doctors do have the John Murtagh actually. I'm taking 1 2 minute of time, guys. Yes. All right. Some people already opened it. Just taking a few seconds. I'm taking a minute time, guys, okay, to open the John Murtagh. You guys can bring those things in a minute, actually. Or you can drink a glass of water in between. We'll be back shortly. Yes, 868, we'll be starting with the asthma. I'm just giving you a minute time, guys. No worries. Just open the asthma section, 868 page. Just a water break, guys, after the demonstration. All right, guys, I'm ready here. Let's get started. Please confirm me in the comment section if it's loud and clear. Yeah, I just opened the John Murtagh. If you don't have John Murtagh, you might be confused. All right. Yes, first class can be confusing. Actually, first 1 week or 2 week can be confusing. I'm trying to be very nice and gentle still so far. I just opened John Murtagh. If you're supposed to have John Murtagh, it is supposed to be crystal clear. This is an asthma chapter, and you are supposed to open 868 page. If you are with iPad, mobile, fancy devices, you will be in serious trouble, I'm telling you. If you're using iPad, you will be in serious trouble and you'll be fail the MC exam, 100% sure. Okay? You need to have a laptop device from the next classes. iPad, sometimes it is okay. Watch Netflix, says this, that, fine. Um Kids go to school with iPad, looks fine and fancy, very small, not a heavy device. You are going for a heavy exam. You need heavy devices, not iPad. Is that clear, everyone? So mobile devices, iPad devices, any tab devices, not suitable for MC. Yeah, orientation, and then we're going for the this class actually. Can we start now? Okay. I think some people already got it, what we're trying to say. Some people are still in that. That's the difference. There is always some good doctors, they understand quickly. There's some backbenchers maybe always, but they get it there eventually, right? That is how the medical field is. But I think we need to start. Okay. The first thing is coming is the asthma 816. Yeah, I wanted to be a little faster in the first class. This is the problem happens always. But as the class goes on, from the second, third class, things get easier. Okay. This is the chapter asthma, and we'll be covering these important things and relevant things from asthma. Great. I'll be taking a whiteboard for some time. All right, great. Starting with the asthma chapter, starting with the first basic question. What type of disease is asthma? You can explain the asthma in four different ways. Now I'll be a little faster than earlier. What type of disease is asthma? Okay, first of all, it is a obstructive lung disease. Second question, is it a reversible or irreversible lung disease? It's a reversible lung disease. Is that an inflammatory lung disease? Yes, it's also inflammatory, or even you can say allergic lung disease. Any title you want to add near to asthma? Obstructive, reversible, inflammatory, anything else you want to add? Yes, well done. Chronic? Can we say chronic word? Yeah. So these are the four terms I like to use for asthma. You can also say inflammatory slash allergic. You can also use that one. Now coming a lot of other things is the clinical feature. Again, four very important things associated with often what are the things? This is something associated with so often. Can we say like, musical sound, shortness of breath, right? Is there cough? Definitely. So cough, shortness of breath, wheeze, anything. What's missing? One thing is missing. That's how we differentiate with the uh, cardiac things. Actually, that's why respiratory and cardiac is so related. That is the chest tightness or chest pain in some cases. So these are the four additional things is necessary uh, to establish asthma. Even with the cough word, we can differentiate some cases with COPD. We'll come back to this point later. Okay. Is it clear about the clinical feature of asthma? Surely we do. Now, is it important? Maybe some of you learned about the asthma. Is the severity of asthma, is it important to assess? Like, is it a mild? Is it a moderate? Is it a severe? Is these things are important? Definitely it is important because either you hospitalize or either you give a home management, a lot of things are involved. So we'll see also stepwise management of asthma today. Shortly, I will show you the stepwise management. So this brings us to the point mild, moderate, and severe. These things are important. And especially with the word severe, there's a lot of other things to say, depends on what antibiotics and what type of emergency management you're giving. So severe of asthma and severity of asthma. So another thing is very important to learn is the severity of asthma. For example, let me give you a very simple term that if someone cannot complete their sentence, like say example, I'm talking, but I'm just even complete a sentence and start uh, having breathing problem. So what does it indicate? So it might be indicating that maybe I'm having a severe asthma. A severe asthma case person cannot complete a sentence. These are often, and of course, his saturation, peak flow, yeah, a lot of things will be included there. A lot of other things would be included there. Speaking about these particular things, reversibility of asthma, this will bring us to another very important point. I'm in general talking about all other, you know, um, respiratory diseases. Can we differentiate all the respiratory diseases into like this obstructive and restrictive? Can you differentiate in that way? Now, where you are putting asthma actually? Where you are putting asthma actually? Okay, we are putting asthma obstructive cases. So we simply remember A, B, C. These are we remember actually. So asthma, bronchiectasis, COPD, other respiratory diseases, like mostly other chronic diseases and occupational lung diseases are restrictive lung disease. Is it loud and clear, everyone? Obstructive lung disease, restrictive, mostly ABC for obstruction, restrictive lung disease, other lung diseases, mostly chronic like interstitial lung disease, fibrosis, and occupational things actually. There's another very important point, the lung function test. Now, are you familiar with this term FEV1 by FVC? Surely you did learn in the physiology class actually. Okay. Yes, I'll be going to take the rest of the subjects as well. I mentioned previously. Okay. FEV1 by FVC. You are familiar with this thing. Now, in obstructive lung diseases, what do you expect FEV1 FVC to be decreased? Can you say like that? What will happen here FEV1 by FVC in restrictive lung disease? This is a nice word, normal or increase. And here we can say decrease. Another thing, if you remember in physiology, total lung capacity, that in general, the lung capacity in obstructive increase or decrease. So in obstructive, so there is residual air. So what do you think? In obstructive lung disease, total lung capacity, okay, let me make more easy. Residual, is there obstruction? Yes. Is there residual volume increased? Yes. If residual volume increasing, your total lung capacity also increasing. So same go, so total lung capacity and so residual volume decrease, total lung capacity decrease. As a fun thing, we often call the restrictive lung disease like an important lung. It does not have much capacities and things that. Okay, so that's how we remember. So residual is less, total lung capacity, it is less. Is it clear so far? This is the basic differences with all the restrictive. This is something we learned in physiology. Now, as a second part of this one, I'd like to differentiate the asthma and the COPD a little bit. Okay. Now, you must be heard that asthma is a reversible condition. That is something we claim. Why we are saying asthma reversible? Now, in asthma, we are expecting FEV1 by FVC ratio is decrease. And less than how much? Less than 70? Can we say? Of course it is. Whereas COPD, even though I haven't taught that one yet, is a irreversible condition. Do you agree with me on this point? COPD is a irreversible condition. All good? Now we are claiming that asthma is reversible. That means asthma probably has a special type of test other than the lung function test. Asthma do have a reversibility test as well. That's how the name reversible or reversibility came. Now, what do we use for the reversibility? SABA, short-acting salbutamol. These are some of the drugs for asthma, right? There are some reliever, there are some preventer. We'll get back there very shortly. Relievers and preventers, actually. So, one of them is a salbutamol. So, if you use the salbutamol, we are expecting a 15% reversible. I'll give you an example. In a asthma, if you do FEV1 by FVC ratio, maybe you find this thing 55%. Now, at this point, you give SABA, okay? And in interval, you keep giving SABA can you reverse it more than 15%? This 55%, can you make it up to 70%? And the answer, it is a yes. If it is reversible 15%, we call it reversibility positive. And this is a confirmatory test for asthma, which I think, learned in medicine at some point. Correct? The same thing in COPD, say FEV1 and the FVC ratio, which is here also less than 70% because it is also obstructive lung disease. So this one is also 55%. Now you give SABA here. Are you expecting 70% here? Unfortunately, it will be maximum like 58% or maybe 60%, but not 15% reversibility. Is this thing clear to all the doctors? So the word reversibility goes with the asthma. They can give you the FEV1, FVC, and the reversibility thing, and you check in the lab and you find it out. Is it asthma or is it a COPD? And give a treatment accordingly. Okay, so reversibility and irreversibility. This is something we're talking about. Now let's getting into John Murtagh. Are you guys ready? Did you get a view about asthma, obstructive lung disease, a little bit about the COPD? Did you get a view? Okay, now we'll get into John Murtagh. It will be easy for us now to deal with. We already learned about the symptoms. So please mark the symptoms a little bit. So take a marker, take a pencil, whatever. Okay, so those are line highlighted. You can just highlight a little bit. Great. There's some trigger factor of asthma. We all are familiar with the trigger about dust, cold, pollen, allergies, drugs, even menstruation, even the ERD. I mean, many things, so which is already given. So in exam, what they might look forward from asthma. So from exam, they might be looking forward drug-induced asthma. Drug-induced asthma, they might look forward. Now, some drugs like aspirin, NSAIDs, beta blocker can be a problem. Now, a popular question which we will see next day in the recall class. Someone probably have hypertension. I mean, not probably, someone has hypertension and asthma together. All right. Um, because of asthma, then they have breathlessness problem, cough problem often. Is it wise to give ACE inhibitor? I repeat, hypertension and asthma. Hypertension and asthma. Is it recommended to give ACE inhibitor? The answer is a no. Why? Because if you give ACE inhibitor, there will be cough, lot of cough. And is it good for asthma? When you cough, you can't breathe. I repeat, when you cough, you can't breathe. So asthma will exacerbate. Asthma will exacerbate. Okay, so that's the reason ACE inhibitor is usually not recommended. Then what is recommended to avoid the dry cough? ARB is recommended. This is a popular question in asthma. So you need to learn the some of the other causative factors in general, but this particular one I mentioned. So ACE inhibitor, just write in a bigger word. ACE inhibitor, do not recommend. Asthma and hypertension, ARB is the choice. This is the number one. Okay, today's extra and very important 5-star we just mentioned. And we already mentioned about FEV1 by FVC by drawing. I hope that's clear to you. Now, a quick question. We mentioned about lung function test. We mentioned about reversibility test. Do we do any X-ray in a asthma? I'm asking you as a clinician. When, as a doctor, a patient coming to you, do we go for a X-ray? Some people say no, some people say yes. But answer, we do an X-ray as a clinician. Is it for asthma? Not for asthma. We do it for what? Because shortness of breath can be a pneumothorax, shortness of breath can be a, anything else. So we do it for the other thing. So here is the point. So X-ray, not a routine, but certainly we do it. But some cases we already knew that this is a clear asthma case. The patient comes to the hospital every winter, then it's a known case. You don't need a X-ray in those cases. Is it clear? I hope it is. All right, moving forward, moving forward. Okay. Mm, okay. There is a special guideline. Normally, we use RSCGP guideline, RCH guideline, RCH mostly for the kids. Okay. And there is a special guideline. It is called ZINA guideline. Z GINA. Okay. So asthma, you can type ZINA, you can find this one. This is one of the biggest guideline for asthma. Okay. Now, in the ZINA guideline, there are some level A evidences. What are those level evidences? One I'm going to reveal right now. We all probably have used spacer in our life for asthma patient, correct? And there's also provision of using this picture, like this is what? This is a spacer. Now, which one is better? Which one is better? Or are they kind of equal? Okay. According to Zena guideline, most people used to think that nebulizer is better, but the reality is nebulizer and the spacer. If you use it correctly, the spacer, in that cases, you will get the equal effect. Rather than it will save patients time and probably life even. Because not every home has a nebulizer, some cases. So in those cases, if you have the spacer and give this particular device, it will give the patient a more space and take it in a sustained way. Single-handedly, if they try to take this device, often they miss it. Actually, taking it properly, often they miss it. Whereas with this one, it works like a kind of like a cylinder for them. Okay, so you can write level evidence spacer equal to nebulizer. Okay, point number one. Please highlight this particular thing, page number 870. My John Murtagh page number is always will be displayed in the lower left corner. Okay, great. Now you can see ZERD or ZORD, gastroesophageal reflux disease, has 30% association with asthma. This is an exam question previously. So please mark this one along with me. We are moving forward, and we just mentioned a level evidence which has been tested as well. So emergency, uh, because do you is this thing applicable in Australia, like an emergency call to the GP? Is this thing applicable? Because every GP has a registered patient. Some of the patients are known patient of asthma. So if they call in the GP center, is it possible they connect to your own doctor in that case over the phone? They don't allow personal number, but you can call to the GP centers. Answer is a yes. If it's a life-threatening situation, I mean really trouble, life-threatening, in that case, you can, yeah. Now, normally you can go and see, that's very much possible, but maybe in middle of night or something like that. So you can call the GP center to connect to your doctor actually. I mean, if it's a GP actually, in that case. Some cases, if not available, they can also mention that one, but and they can try actually. Yes. Yeah, after hours. Yes, after hours. I'm saying night means it's after hours. Better word is after hours. Okay. Now, if you get that call and telling that, doctor having this issue, so in those cases, they try, do you have the spacer at home? Okay, relax. Please use the spacer. Yes. Mhm. I hope so. You must be knowing about the situation in Australia about the emergency. I mean, unless it's a life-threatening condition, they even keep you waiting in the emergency room for a very long time. It is true. Okay. Now we are speaking about lot of uh, grades of asthma, like a mild, moderate, and the severe. Now, they believe what can be done simply, or if the patient is not dying, they don't take any initiative. Those of you living in Australia, you know the reality, right? I mean, unless the patient is not really dying, other than even my sister just few days back took her son to the emergency. They were waiting for 5 hours. It's because they said, okay, it'll be fine. Whereas another person was sitting next to them, suddenly that person fall, and from every room, all the doctor came up immediately. Okay, the same thing, like they wait for the life-threatening situation often. So, which can be done. Some cases over a simple consultations and this that they try to solve it in that way actually. So less hospital visit, more like a preventive. That is their motto. Okay, coming to this one, asthma has a lot of grades, mild, moderate, severe. So severe needs, salbutamol, like a reliever, and they also need preventer. We have another slide at the end, okay, which I will show you shortly. Saba and the Laba and also fluticasone, some cases, moderate cases, Saba, Laba again. By the way, very severe cases, you might need oral prednisolone as well. Oral prednisolone as well. Yeah, in the very severe cases. I just want to highlight one thing here. Some people always does not have asthma. I think you have seen that one. Sometimes, I mean, once or two times in a year. Have you seen patients like that? Will you count them as like a regular asthma patient? Not really. They're like intermittent, maybe once a year or maybe twice a year. That's not a real asthma patient always. Okay. They might have or something might exacerbate. In that case, what we give them is an occasional SABA. There is no preventer and nothing required. This is a MC handbook question and one of the popular exam question because this is a very common one which comes to the GPs. Okay, doctor, I mean, I don't feel why this time happened. There was nothing last year, and now this time this year it happened. So okay, initially maybe you got too much cold and this that. That's how it happened. But they keep asking question why this thing. So we count them as a intermittent patients. Okay, and in that case, Saba. So and they will again ask you that do I need to keep using inhaler? No, you don't need to keep using inhaler. It's just one time thing. So clear everyone. So now previously we maybe learned in MBBS mild, moderate, severe. Now learned in another category. It is a intermittent category. Okay, and from here it's a 5-star. It has been tested. Great. Moving forward to next page. Uh, Page number 872, reliever, preventer. Preventers, of course, is this ICS and steroids and this, that. You can see one thing. Steroids is a lifesaver. I'll add a very short story. I don't take much time, just 1.5 minutes. When I was in the respiratory course, as per module course, long back in Bangladesh, later I also took a separate degree on UK on respiratory. Uh, while taking the training in Bangladesh, I remember this one of my senior who was sitting next to me was regretting. I wish I saved that patient. So why you saved that? Because the relative call late night and this night. Now, how did that term came up? Because our professor was teaching us never ignore, never ever ignore a night patient or a night call. Okay, so he received a night call from one of the relative, and there's some cases, some poor like village relatives and things. So he said, those drug I gave you, please take them or maybe go to hospital. Because those are poor patient didn't go to hospital. Next morning he heard the news, the patient died. Okay, so he was regretting why? Because the patient had the simple inhaler and maybe the long acting ones, even maybe the ICS one. But why the patient died? Can you tell me? One thing is, of course, not going to the hospital, but what else he could have been given there? So what he missed is actually failed to prescribe the steroid. Is the ICS enough? When it is extreme life threatening, is ICS inhaler is enough? Not really. It's not enough in that case. In that particular time, you need the tablet prednisolone or injection hydrocortisone, and you need proper hospital setting some cases. At least if you give the tablet prednisolone, it's a lifesaver. Okay, so that is something he was regretting, when we was taking the, training. Yeah, that I wish, I said that patient that day, maybe mentioning, okay, go and get that particular drug, prednisolone. Yes, right. All right. So this is important. Speaking about the preventer, one is a ICS, one is a ICS. What is another thing if you can name one, another preventer other than the ICS? ICS means inhalational corticosteroid. Another one is a sodium chromoglycan. Sodium chromoglycan. It's a popular one. Often I like to add something in that way. It's a very, very popular, another 5-star. So 5-star topics I've been taking care of here, particularly like this. SCG. sodium chromoglycate. Okay, often for the children. Okay, so as a preventer, one formula to remember: uh, if less than 5 year, you go for the sodium chromoglycate. If more than 5 year, you go for the ICS. Now, why is that? Can anyone tell me why is that? If you keep the ICS before 5 year, there will be side effect. Okay, unless special situation cases, you don't need to give the ICS actually. Or some cases, in some of the recall question, there is no option for the ICS. So in that case, you have to choose the ICS. Okay, but less than 5 year as a preventer. Preventer means normally they have tried the salbutamol and this that, and after that they're looking forward to a preventer actually. So in that case, this is a popular 5-star thing, and we'll see a lot of question next day on that one. So sodium chromoglycate. Another special line, I will ask this thing next day. This is also can be given in inhalational route. Okay, sodium chromoglycate also can be given in a inhalational route. Next day we will see why I mentioned that one. Clear? Great. One thing to clarify, patient often asks us this thing: doctor, you give prednisolone, it's a steroid. Am I going to have side effect for that one? What's your take on that one, guys? I think it's a common thing in the practice. It's the short-term thing. Yeah, and also risk benefit ratio, you have the benefit more over the risk actually. It's a short-term thing, usually does not have any particular side effect. Please mark this line. SCG, sodium chromoglycate, also has, uh, mark this one. So nebulization or inhalation route. You'll see a question next day regarding this. I know it's a little complicated. GIT next day will be more easy. Respiratory, I find a little complicated some cases. The next topic is coming. I mean, you might find a little bit uh, clear view on that one. Exercise-induced asthma. I'd like to ask in that way, what do you think? In case of someone having asthma, do you recommend them to play football or cricket? I mean, basic question. A child's mother brought a child. Can my child can play football, cricket? Of course he can play. Why he shouldn't be? Oh, oh my God. No, you can't hamper these things. Yeah. But with precaution, with a limited time, you need to be careful on that one. Of course he can play. Okay, that's a like thing that you cannot do. I mean, general hampering. That's why Australia and all the big countries they work on the preventive things, how to maximize their thing. Now, what's the take on that? Usually, what we recommend them, you take a puff, I mean, 2 puff of salbutamol, few time before the play. Okay, few time, 2 puff, 5 minutes immediately before the exercise or before the 2 puff, 5 minutes before the play, salbutamol. So can we say that salbutamol is the best thing for exercise-induced asthma? Give a 5-star here. This is a tested topic. Okay, this is a tested topic. Also, according to the RCH guideline, it is also uh, most or best preventive way, best preventive way to avoid exercise-induced asthma. This is the exam question. Loud and clear, guys. This thing. I hope it is. Asthma is the bigger part here. Um, Don't worry. New addition to 8th edition. Yeah, you can have a look a little bit. This chart is also available at the end, so don't worry. It's just a nice, colorful. Okay. Have you heard things like that? When a asthma patient came and they're complaining, my asthma is deteriorating, always check the inhaler technique. I even saw a patient. Okay, can you show me the inhaler technique? He's spraying like this, like a perfume. Maybe you can see in the YouTube like bloopers or inhaler weird techniques. You will find so many in the YouTube actually. You can also share like some people are using from nowhere, but you will find always a problem in the technique. Okay, so this is another. popular thing. So they will bring questions like that. Okay. Next, 877 page. Already I mentioned that one. Spacer and a nebulizer, similar effect. So you can mark this thing. It is important. And here is a thing, dangerous sign of asthma. This particular box is not present, unfortunately, in this one. But in my note, you will find it actually, and because I just brought that Davidson note. So here they differentiated acute severe asthma, life-threatening asthma, near fatal asthma. I'd like to ask a question here, that how can you differentiate severe asthma versus like life-threatening asthma where the patient is literally dying? Can anyone differentiate which point? Because this is a tested topic in the exam. So I'm highlighting all the important tested topic after a little going through the asthma basics. The main thing is all of this condition has, hypoxia, right? Acute severe asthma, life-threatening asthma, even near fatal asthma. Let's take the near fatal asthma. This one also has a hypoxia thing. Okay, saturation will be dropping. But is all of them is having hypercapnia thing? The next question is all of them is having hypercapnia thing. Like that means uh, PaCO2, not really. Like near fatal asthma is a PaCO2. This is the indication for mechanical ventilation. So your question will be given in this way, that which one of the following required intubation? Asthma patient required intubation. Asthma patient required mechanical ventilation. Okay, so it will be partial oxygen, or you can say then, the metabolic, you know, uh, differentiations would be there actually. Okay, so partial patient of carbon dioxide. Hypoxia is common for all of them, common factor, whereas in near fatal asthma, hypercapnia. You must be heard about the respiratory type 1 failure and type 2 failure, right? So near fatal asthma, is it a respiratory type 1 failure or type 2 failure? Of course, because hypoxia and hypercapnia together, it's a respiratory type 2 failure. Everyone clear about it? I hope it is. And some signs of asthma is given. Okay. I know it's a little boring chapter, but we don't have a choice for this one. GIT is much more interesting. GIT, cardio, those things. Cardio, some people are afraid, but you'll have fun. Okay. Here is a six you need to learn. It's a rule of six. Okay. Guideline for using the asthma initially as a spacer. Okay. So 6 puff of salmeterol in the beginning, it's been always recommended, but we have to check out the age group here. This part is little difficult, so I want you to all focus here. If less than six years started with, the basic is like every like 20 minutes, we're trying to do this, give this salbutamol thing. So less than 6 year, as a repetition, we give a 6 puff of salbutamol. If less than 6 year, okay. Uh, if more than 6 year, then what? Which is not very clearly given here. But if anyone from the previous batch, they must be knowing. If it's more than 6 years, okay, 6 years or more than 6 years, in that case, it is a 12 puff actually. So it's not only the weight, you can also improvise here that as a 6 or more than 6 years. So here you can write extra near to 35 kg, 6 or more than 6. You can go for a 12 puff in that case. Is it clear, everyone? Next day, I will show you how that questions solving the recall related to this actually. All right. So this is something to remember for the exam. So as many adult and children were learning together, shortness of breath, wheeze, these are the common. Adult, child, both have the wheeze thing. It's very loud and clear. Um, Understanding the using the inhaler. Can a very small kid can use an inhaler? I mean, think about a basic thing. I mean, when you're recommending like a quickly inhaler things, can a small kid can use an inhaler? Like a answer is a no. But if you add a spacer with that one, can they use it? Answer is a yes. It's like you can just show that, and some of the spacer also has cartoon. See, this is nice. This is a space. Please, put your mouth. It'll be in the space. Looks like that. Yeah, definitely nebulizer is a, like, if possible, because it has a mask and things, but along with the spacer, you can also add a mask near to that. Spacer also has a mask actually. Options available. Clear? So nebulizer with a spacer, and you can also add a mask near to that. Yeah, that's the point. Not everyone has a nebulizer, or sometimes that time from home to go to nearby nebulizer, patient may be in danger actually. This is the point we're looking forward. This is another 5 star. Put your 5 star here as well. Here. So mild, moderate, severe. They will put you in situation. I mean, you may have a little hard time to differentiate. Is it a mild, moderate, or severe? Okay, you will be a little confused in the exam. As we already mentioned, mild cases, or there is another option we mentioned. You can put here as a intermittent. So intermittent asthma, occasional salbutamol. Already that one mentioned. Previously there was a slide. Now here is another slide. As you can see, mild, moderate, severe. Now, how I understand this is a mild. Now, if you have this thing like a more than uh, 2 monthly, like in a 6 month, you are having one attack, or maybe 3 month or 4 month, you are having one particular attack, it is possible that you are under the mild category. So 6 to 8 weeks. So it's like a 2 monthly. So every 2 monthly, you are having an attack. But if you're having a 6 monthly, 1 yearly attack, that's intermittent. If you're having 6 to 8 weeks, like 1.5 month to 2 months, let's say 2 months, you are under the mild, and you use the SABA during the attack, uh, maybe necessary steroid during the attack, but you keep using the SABA in that case. Okay, so tell the patient, you need to use it for some time. Moderate cases, now you see it is something dropped down less than 6 weeks. Now, if you're having more frequent attack, less under like a less than 6 weeks, like a kind of like a monthly attack. Is it clear, everyone? So one is like a 2 monthly attack, and one is like a monthly attack, just for understanding purpose. Now, not only SABA, you are also adding something preventive. Is it clear? So monthly attack cases, you constantly need to use the preventive. What are those preventive? Mostly ICS. If it's to a small kid, in that case, sodium chromoglycate. Okay, clear. Last point is a severe one. Previously 2 monthly, 1 monthly. Now, is it a monthly? No, it's like a weekly. Now, if you're having weekly attack, or at the night time you are having attack, is salbutamol and ICS enough in that case? Not really. You need to save the patient. As I mentioned that story, in that case, you need to add what? Oral prednisolone. Is it clear to everyone? You need to add now oral prednisolone, because it's a weekly thing going on. You need to continuously give the oral prednisolone or a short course of prednisolone to bring the patient from the moderate, upgrading him to the severe to moderate grade change actually. Then you can take off the oral prednisolone. Okay. Is it clear to everyone? So intermittent, mild, moderate, severe. Three things totally. Three or four things you can say. Okay. It's all the time difference. Like a 2 monthly, like a monthly, like a weekly. And severe and also has a night symptom. You can remember that story I mentioned. Is it clear to everyone so far, whatever I'm trying to say? And a special line, preventive cases, if less than 5 year SCG, more than 5 year fluticasone or ICS. Okay. Here's few lines are given. And here is a chart given about asthma COPD, but this is also available in our note, like a asthma and the COPD difference. I'll tell you a basic clinical difference actually. I mean, both looks quite a similar. Also, if you are a respiratory consultant, you must be knowing there is an overlapping condition, ACOS. Have you heard this name? I mean, asthma and COPD together. Have you heard this name, ACOS? Yeah, asthma and COPD all together, it can happen actually. So it's a lot of confusion between asthma and the COPD. But one of the basic difference when you ask the patient, okay, you have breathlessness, yes, you have cough. Which one do you think is more prominent? We ask this patient. If the patient is saying, no, I think that like my breathlessness, this is the major problem, then you probably is suffering from asthma. If the patient is telling you that, no, I'm suffering more with the cough thing, I'm troubling my quality of life, hampering more because of the cough. So the next question, do you get up with the like huge amount of cough early morning? Yes, definitely. How do you know, doctor? So probably you're suffering from like COPD type of cases actually. And do you smoke? Yes. Okay. And asthma, which started from the early life, most cases. COPD started after the 40 and a common smoker. And cough is the so because of the cellular changes, hypertrophied of the cell because of smoking, there's more production of cough actually. So they get up in the morning with ton of coughs. Okay, so that's how we diagnose COPD. But clinically, it is not enough. You need the reversibility test. Okay, so you need the reversibility test in general to confirm it for further things. And clinically, some of the significant finding you might find with the asthma and the COPD. Yeah, in the next chapter, it is COPD. I'll not go like extend with the COPD most kind of same, but they are mostly smoker, more than 40 years. Treatment is same as asthma normally, but one particular drug which is more predominant in COPD. Can anyone tell me which one is that? Like we are saying salbutamol is a predominant drug, and later we need a prednisolone. But in COPD cases, ipratropium bromide. Okay, ipratropium bromide. So that is a predominant drug there actually. Okay, Lama. Yes, well done, guys. And special clinical feature. I mean, ways and these things are common, but there is a if this term is given barrel shaped chest and a smoker, you are going for a COPD. Okay, great. And of course, if this is somehow mentioned that reversibility test is negative, then you are full sure that this is a COPD case. And of course, you might need a longer dose of antibiotic in COPD in some cases. Agreed? Some cases you might need a longer because infection is a very common thing in COPD. All right, great. So, as I said, asthma is a five-star. COPD is like a two-star topic, like not much that tested actually. So, 861 page, that is the asthma, 881 page, that is the COPD. And among the obstructive, okay, I couldn't highlight. Think much to highlight. I'll give a tip actually for the COPD. Actually, it's given actually in COPD. I mean, you can just follow that. Our SMA note would be enough. But for highlighting purpose, I'm brought back this line. Okay, highlight smoking, cigarette smoking. Yes. Another COPD divided into bronchitis and emphysema. Emphysema can be genetic some cases. You can mention as the alpha 1 antitrypsin deficiency. So if you are asked, is it possible COPD can be present in early life? Yes, rarely possible when it's because of alpha 1 antitrypsin deficiency. That's the one rare thing about the COPD. Okay, yeah, I'll put it here. Symptoms and some of the things. Necessary things I will be always telling you, don't worry. A quick question in asthma, COPD, or any breathlessness cases, is it necessary to do an extra test? An extra test, what extra test I'm talking about here? ABG? Is it necessary some cases? I mean, say extreme severe breathlessness cases. Yes, because some of these cases it depends on type 1 or type 2 respiratory failure. You might see acidosis or this kind of clinical features. Okay, good. Now getting into a topic, a little different jump because bronchiectasis is discussed in a separate place. Okay, after bronchiectasis thing, we'll be taking a short 10-minute break actually and bring back with the other topics actually. Okay, I'll be taking the screen just for a second to bring our SMN node. Just 1 second, guys. In a minute, I'll be showing up? Yes, we are ready. Okay. So we do have a note here as a bronchiectasis. And we also opened the John Murtagh. So John Murtagh page number is uh, 397, guys. Yes, 397. It is highly recommended. You need to have John Murtagh 8th edition hard copy for AMC. This is the only book probably you need. As a even uh, handbook you can read soft copy. I don't mind. Okay. So I mentioned as here, like you can go through our computer node. Let's see what it has. So it's a chronic disease. Yes, bronchitis is obstructive disease, chronic disease where we have a dilatation of the bronchi or the bronchiole. Are you expecting a lot of cough here like COPD? Yes. Is it again a very basic question, reversible or irreversible condition? Bronchitis, reversible or irreversible condition? Bronchitis is a irreversible condition, as like the COPD. So again, few things like the cough is the more prominent feature than breathlessness. The cough comes first actually than the breathlessness. Okay, with a bout of some cases, blood comes up because there's a lot of permanent changes actually. Okay, so things are given. This is our note section. So cough with a sputum, then there'll be crackle in the lung. Okay, this is characteristics. So abnormal and permanent dilatation actually. Are they smoker? Often they are smokers actually. Very interestingly, is it possible to have clubbing here? Actually, yes, that's a possibility. Okay, exacerbation, worsening symptom more than 2 days. Required treatment changes. Yes. Anyways, yes. How bronchitis I have seen in MC so far. I have put a star here because one time there was a CT scan given, and we can see and detect from this particular radiology that there's like a more dilatation than a normal CT scans actually. So abnormal and some permanent dilatation we can see. So this is so CT scan is popular for the bronchiectasis cases. So this is one of those CT scan actually abnormal and the permanent dilatation. Some people also difficult, but if you think as a tram line, maybe you will find a tram track appearance actually. They're hard to detect actually. All right. And it's not common nowadays because this disease has been diagnosed so many years back. That time, tram used to be popular. Nowadays, people don't much use tram, except for some European countries. They also keep having tram. I think Australia does have also tram, actually. Yes. All right. So, bronchiectasis. Here is some extra points. Now, you must be asked, other than the CT scan, what is the most accurate test for bronchiectasis? High resolution CT scans. Clear, everyone? So, CT scan is the mainstay. Among the treatment, I mean, other than the, that basic drugs of distress, salbutamol, and many other those things, it is absolutely important to give a antibiotic for longer time. Many bronchiectasis patient, you need to have prophylactic antibiotic so that they don't get bad microorganism like pseudomonas. And a very, very important and appropriate would be there. This is one thing I don't know, but 3 months back I saw this question coming. Chest physiotherapy for bronchiectasis. Did you heard about this line? Chest physiotherapy for bronchiectasis, actually, like a tapping on the chest and clearing all the cough, actually. So, which is quite appropriate. Initially, appropriate is to tapping. Our professors also used to come, okay, tapping the chest is very important. And then they prescribe the antibiotic, this, that. So tapping the chest or chest physiotherapy is initially very appropriate, actually. But if it has most, probably not, actually. Great. Anyways, guys, you can check these notes later on. And here is few things about the bronchiectasis in John Murtagh. No palate indentation, clinical features are given, examination finding, including clubbing and crackles. Some microorganism names are given. Please remember them. A quick question. This typical microbiology tested? Not really. But do they ask about microorganism? Answer is a yes. Okay. So example, pneumonia, which is our next topic after the break. Do they ask about the microorganism related to pneumonia? Answer is a yes. So microorganism related, they do ask questions actually. Okay. But the typical microbiology, they don't ask. So you can see pathogens. So CBC and blood culture is important here. Alongside CT scan, lung function test are important. And of course, chest physiotherapy, antibiotic, and bronchodilators, of course. Okay. Is it clear to everyone so far? ABC, asthma, bronchiectasis, and COPD, are these things are clear so far? Okay. We'll get into a more interesting topic as the next one, which will be the lung cancers actually. And lung cancers, so we will find in page number 395. Okay, so we'll take a break here and we'll come back and show you about the lung cancers and bronchial carcinoma, pleural carcinoma, following pneumothorax actually. Okay, great. All right. Is it okay to go for a break? But don't go away, don't leave classes. I mean, I know it's going to be long in the first day because we have to go through the demonstration. Yeah. But don't worry, we'll be posting the recording tomorrow. You can see that one, in this group, or we'll post also a version in the YouTube at the same time. Great. See you all after 10 minutes, guys. Okay, so I'm going for a break now, guys. We'll be back. I'll see you guys in 10 minutes. Okay, those of you are um, in a process of admission and this, that, you can leave a message in my inbox. Thank you so much, guys. Facebook Messenger, Facebook inbox, the blue tick one. Thank you, guys. Take a break. I mean, very important. After we back, lung cancer, mesothelioma, sarcoidosis, occupational pneumonia will be finishing. The major one was asthma one. The next ones will take lesser time. Thank you. Okay, everyone, I'm back after the break. Okay. Yeah, live tutorial will be uploading. I mean, will be available in this particular group and also in my YouTube channel because first two, three classes we post there. Great. So thank you so much, guys. So let's get started. Great. We'll be starting bronchial carcinoma or the lung cancer from page number 395 page. It's requested to open up. Just taking a second to bring up our note. Yes, please. Okay, ready, everyone? So bring some energy, long classes. I also need energies, guys. Yeah, so I get energy from my students, actually. Great. Yeah, like you were right, actually. Before the next week, Thursday, you should, keep reading these topics, actually. You are absolutely right, my dear. Great. Okay, guys. Someone asked this question in the chat box. Should you study this topic till the next Friday? It is. Yeah. So mention as like a yes or something in the comment section, whoever attending the session. Thank you so much for, I think 10 people left in between the break. I think could be a lot of reason. I hope so. They will be back in any ways. So great. John Murtagh, you need hard copy, my dear. Thank you so much. We provide a lot of soft copy of the books. This one I use for the class. Thank you. Okay, coming back to this one, lung cancer, exactly what you need for the exam, actually. Great. Right. So here's few things, important things for the exam for the lung cancer. It's actually lung cancer and also mesothelioma. Mesothelioma will be talking in a second. And uh, investigation is very important for the exam. Some of the clinical feature, they'll give you a scenario. You need to make a diagnosis with lung cancer. This is another important. And even types of lung cancer. For example, small cell carcinoma, squamous carcinoma. This thing is also important for the MC exam. Great. We already knew about some of the lung cancer details. So unexplained, you see weight loss, there'll be breathlessness, there'll be cough, okay, and then anorexia. Okay, so weight loss being the one of the major feature in the beginning, and followed by cough. Later can be hemoptysis and all these things. All right. Now here is a little bit thing about the lung cancer. Okay, one thing I wanted to highlight for all of you here. I hope so you can see this picture about the lung cancer. Um, I'll go to the nutshell later. But if you can see the nutshell, SCC is the most dangerous lung cancer among all the types, but I'll show you the types certainly. Then squamous is one of the most common. Squamous is one of the most common, so don't worry. And there's a special line. Please focus on classes, my dear doctors. Adenocarcinoma is often as a hidden, and a spatial line is a bronchoscopy. I mean, sometimes we do lung biopsy, sometimes we do the bronchoscopy. So these are features. So bronchoscopy if it is central. Now coming back to this one, and if your cancer is near to bronchus, then we go for bronchoscopy. If cancer is little peripheral, then we'll go for the typical lung biopsy. Whatever the way, it's quite a painful thing. Um, the lung biopsy. I did have a relative, he had a lung cancer. So he mentioned that I wish I died rather than having this biopsy. It was that painful for him. You can understand how painful are the procedures actually. Anyways, eventually he died. About him, at the time of his diagnosis, is already been metastasized in some regional lymph nodes and this that. So surgeons couldn't take it out. He was given some chemo, but It didn't go well. Eventually, he died under a year. Can anyone guess what kind of cancer was that? I'll give you three options: SCC, small cell cancer, adenocarcinoma, squamous cell carcinoma. By the way, squamous cell carcinoma is being the uh, popular one. Okay. So he died because of actually adenocarcinoma. He died because of actually adenocarcinoma. Now, about adenocarcinoma, I'll tell you more about adenocarcinoma. Normally, quite away from the bronchus. Okay. So when we make the diagnosis and we see in the X-ray and the CT, another information which I didn't give you, it was little away from the lung. Now, was it become beneficial or was it become bad for him actually? The lesion was away from the bronchus. So because it was away from the bronchus, it shows up much later. Because when it become quite big, then it comes to the bronchus, then he starts suffering with the breathing issues. So initially it's just a cough. Initially it was just a cough and maybe a little weight loss, which at his age was like 65, which was quite a common. So it was like hidden. So it was in the peripheral. Along it came to the bronchus and it has other branches to the lymph node, then we get to know it actually. Okay, so it was not only a coagulation, it was getting bigger in short summary. So peripheral cancers are asymptomatic, and name one peripheral cancer is a adenocarcinoma. So name one peripheral cancer is adenocarcinoma. This is the thing. And central cancers are squamous cell carcinoma and squamous carcinoma and small cell carcinoma. Out of all the lung cancers, which one do you think is the most dangerous? Answer: small cell cancer. Small cell is the dangerous. Even it is said at the time you get the uh, result, maybe you send a biopsy or something, after 5 days, the result can be changed. It is that aggressive. Now, coming to this point, I'll make it a little enlarged. How question would be tested from this part? Will they ask directly about the types? Technically, yes. They'll give you in that way that a person who is having weight loss, anorexia, and cough and hemoptysis, it means lung cancer. Now, how could we differentiate the type? And they mention it's quite a symptomatic, and he probably has some, mm, Cushing syndrome-like features. Is another hand, which we call paraneoplastic. So one is a typical lung feature, and now is a paraneoplastic feature. Now, I mentioned the Cushing feature, Cushing related to cortisol, cortisol related to ACTH. Now, which one here? You can see the word ACTH, ACTH controlling the cortisol in any way. Answer: small cell carcinoma of the lung, and which is also a central. So, which is also a central ACTH, and also it can be ADH, like syndrome of inappropriate, because more ADH, SIADH. Okay, so we need to remember. So Cushing and SIADH are the two paraneoplastic feature of small cell carcinoma of the lung. If it is said again, weight loss, say weight loss, anorexia, okay, typical cancer feature or cough hemoptysis, alongside patient is having a paraneoplastic syndrome like a uh, high calcium in the body and some personality change, and PTH hormone thing is elevated as a para um, thyroid feature. Now, which one do you think we're talking about here? Now, you can see if anywhere, PTH thing is written, and if you can see in the chart, it's written alongside with a squamous. Correct? All right. So this is the point. This is the very, very important point. Like they'll give you some clue and you need to find association. In generally, they will give you lung cancer feature and one or two paraneoplastic feature. You just need to catch them quickly. Is it clear so far, everyone? I mean, how to um, pick up the questions from here? I hope you understood. And already mentioned about one of the relative. He was diagnosed. He was asymptomatic and he was not a smoker even, and but he died because of, and we couldn't make the diagnosis early because it was in the periphery. His diagnosis was adenocarcinoma classic. Okay, I hope that's clear. And some cases you might find from other part of the body, metastasizing to the lung. Is it possible? Of course, from liver it comes to the lung. From other part it can also come to the lung. That's another type of the metastatic lung cancers. Okay, is it clear so far? These are in general some of the paraneoplastic feature. In short, it is called sphere. Okay, in short, it is called sphere. You can check that one. Like often, a lot of lung cancer can be related to superior vena cava obstruction. Which lung cancer I'm talking about? Which lung cancer can be related to superior vena cava obstruction? If you turn the face, there will be flushing of the face. Turning the face, flushing of the face. Superior vena cava obstruction, apex of the lung tumor. Speaking about Pancoast tumor, spatial feature, is it anything? Horner syndrome. Spatial feature would be Horner syndrome. And the sign, turning the face, flushing of the face, called Pemberton sign. Pemberton sign. Yeah, great. So here is few things. Small cell carcinoma, ACT8ADH. So Cushing, SID, it's already given in the note. And SIADH related little information, Cushing related little information. This is how our more notes looks like. These are more exam specific. And another special thing they will ask you related to asbestos. Do you have any idea about the asbestos? Say, the painting in the houses, especially if you go to Australia, UK, they have sometimes, especially in the old cities, a lot of old houses. Okay. And it's a possibility that some of the old houses may have asbestos. Now it's no longer kind of available, but previously, or maybe some of the museum, I don't know, some places still it can be. Uh, Asbestos, which is related to asbestosis, occupational lung disease, it can lead to cancer if you like in that place for 15 years, something like that. So it can lead to lung cancer, it can lead to mesothelioma. Now, an interesting question asked in MC, asbestos leading to which type of cancer more? So see, statistical or population health type of thing, uh, uh, they ask often actually. So they also put lung cancer, they also put mesothelioma. Both can happen because of asbestosis. But the main answer was lung cancer. Lung cancer is a common thing, whereas mesothelioma, because mostly as the occupational, we remember mesothelioma. Mesothelioma is an extremely rare thing compared to the lung cancer, which is quite a common in case of plumber, roof installing, wall installing. Okay, so this asbestos thing is quite common in a case of plumber, like a rooftop workers or wall fixers. These are the things actually. Okay, last but not the least, yeah, you'll find me in this name in everywhere, Instagram, Facebook, YouTube. Anyways, um, coming back to this one, what is the chain of diagnosing of lung cancer or most of the respiratory conditions? Most of the respiratory condition, how you want to make a diagnosis? Investigation for lung cancers. First of all, starting with the as X-ray, then going with a CT scan. Some people say CAT scan as well. Or lastly, biopsy. Okay, so you can put things like that as like a, often they will ask you a lot of questions from here. Trust me, it's quite a popular. Two and the three. Often in the question, it's given like this. X-ray done. X-ray, here is the X-ray finding. What's next? Answer, CT scan. You'll be given X-ray CT scans are done. You already know some of the grading things. What's next? The next is a biopsy. Now, even if you know by CT scan this is a lung cancer, why still you need the biopsy? I'm asking you in generally. Even by CT scan and X-ray, we'll get to know it's a cancer. Then why I need that biopsy? Answer, the exact typing, exact staging typing mostly. Like, is it a squamous? Is it small? Because different chemo and all these things, you need, if you know the type, it's more better. I hope that's clear for the lung cancer. Now we'll go to like one thing, which is the mesothelioma. Ready for it? Okay, let's go here. I think just near to, so let's get into John Murtagh, guys. Let's see what's in John Murtagh. You see bronchogenic carcinoma, classic. Mm, the age is mostly after 50. Cigarette smokers, we all know it. If you smoke, you might get lung cancer. So 50 to 70s. Um, Cough can be one of the early feature, whereas weight loss is the most prominent feature, unexplained weight loss. And you can write this thing near to the investigation, page number 396, one X-ray, two CT, three biopsy. You will be needed this thing for the exam passing. Some features given here about oncogenic carcinoma. And here we go. We do have this thing, mesothelioma. Mesothelioma mostly given as a occupation, occupational, and it will be presented with a high chances a CT scan or a X-ray possibility. Now you see the right hand side, there's a normal CT scan given, and in the left hand side, can you see the differences? Please comment in the comment section. I think we can see very characteristics differentiation. Can you say this pleural part is very thickened? Can you say mesothelioma is a cancer related to pleura? Okay, so cancer related to pleura, very thick pleura. Now, can you be able to breathe properly if you have this thick pleura? Answer is a no. So there will be cough, there will be breathing problem. Um, so it'll be issue because it will be having a little narrow space. So chest tightness, chest pain, breathlessness, weight loss, and of course pleural effusion. Pleural effusion. Do remember, even in the lung cancer cases, there can be pleural effusion. Mesothelioma cases, there can be pleural effusion. So pleural effusion is a disease, or is pleural effusion is a presentation, guys? Pleural effusion is a presentation actually. And I mean, all you need is a exudative and transudative causes. Okay, I'm not teaching pleural effusion separately because it's a very much MBBS thing. So just check it out one time. Causes of pleural effusion, exudative and transudative by yourself actually. So pleural effusion, if it is present, uh, probably indicating it can be exudative cause of pleural effusion. Exudative cause can be lung cancer, mesothelioma. Okay. Is it clear to everyone? Last question. The prognosis of mesothelioma good? Prognosis of mesothelioma bad. Answer. The prognosis of mesothelioma is bad. Still, everything depends on staging and grading, but most cases, the prognosis is bad. Even the lung cancers, most cases prognosis is bad, but it still depends on the staging and the grading. Okay. A very famous cricketer diagnosed with lung cancer, if you remember. Yeah. So it was very shocking because he was playing cricket and at top of his form, probably. Anyone remember the name of that cricketer? Yes. If you mentioning Yuvraj Singh, I think you are giving the right answer actually. I hope you remember that. Yeah. Okay. So I mean, it was challenging, like, because cricket and these things are sports needs very high intense fitness. So he had that tumor and he recovered and he came back and even he started playing and played successfully. Okay, so that's quite amazing. Okay, so lung cancer and the mesothelioma. Are we clear? Last but not the least, X-ray, X-ray, CT scan, and the biopsy. This is the investigation for the mesothelioma. Surgery, quite difficult in case of mesothelioma. So treatment is mostly palliative or supportive. Okay. Everyone clear about it? I hope it is. Okay. This part we done. Well, going to end. I mean, just three left actually, not much. Don't worry. Um, Here's the thing about the sarcoidosis. It's a multi-system disease actually. Along with sarcoidosis, we'll be also learning the occupational. Means mostly the asbestosis we already learned actually. Okay, so and another one is a coal miner actually. So those work in a coal mine can also get occupational lung disease. And a special feature about all the occupational lung disease, they have ground glass appearances. Okay, and some cases they get crackles alongside slow breathing problem. Later on, they might get like a crackles, these things. Okay, we'll get back there. But sarcoidosis is a very, very important and popular one for the exam. Sarcoidosis also have note, but I think this part will be also enough. Sarcoidosis, is it a obstructive or the restrictive lung disease? It is a restrictive lung disease. If you know the ABC rule, ABC are obstructive, sarcoidosis and some of the occupational and relevant like fibrosis, interstitial are the restrictive lung disease. Also, it is a multi-system disease. Now, why it is mentioned multi-system? But because you can see it affects the lung, it affects the skin, it can affect even affect the eye. Okay, so a lot of involvement in even the lymph node. Now, can I say one of the characteristics feature of sarcoidosis is a hilar lymph node? Did you remember this point? That hilar lymph node. So bilateral hilar lymphadenopathy. So they will give you an X-ray, and it will be given like both of the side there will be coin type of thing. So it will be hilar lesion. Okay, and a special thing for AMC to remember, which you should mark separately as a 5-star. The skin lesion is a erythema nodosum. Erythema nodosum for this particular condition. Erythema nodosum. Now I'll be showing you in the note in a second for sarcoidosis. If anyone joined late, we have our class schedule in the group file section. You can check it by yourself. Now, let me show you about the sarcoidosis. Two things about sarcoidosis. One, I want to highlight, first of all, is that particular X-ray about the sarcoidosis, hilar lymphadenopathies. Hilar lymphadenopathies. Okay, so this is one characteristics. By X-ray, you can make a diagnosis. Furthermore, you can go for CT scan and biopsy if needed to rule out the other problem. Uh, this box is related to a Davidson box, as you can see, because why we mention multi-system, because eye involvement, lung, also lymph node, bilateral hyperlymphodenity, even cardiac involvement can be there. Another very important thing is involving the skin as a erythema nodosum. Have a look on that one. Erythema nodosum. And liver, spleen, and so organs can be affected at the same time in case of sarcoidosis. So I make a highlight. You can see that one in the note as a X-ray, then erythema nodosum. Then as like a physical examination, you can see rarely some crackles and also like lung functions affected. You must be knowing about now, like what are the finding of restrictive lung disease? Okay, so restrictive lung disease, all the findings. FEV1 by FVC can be increased, total lung capacity, this thing decreased. We already discussed this part. Okay, great. And as you see, chest X-ray, then some of the things, enzymes can be raised like ACE inhibitor, calcium, CT, later if needed, biopsy. Okay, so these are the things. Yeah, later is a biopsy. Is it clear to everyone? I mean, about the sarcoidosis? Okay, so initial X-ray, then CT, further confirmation is a lung biopsy. A rare thing I found in one of the um, particular exam, it was not mentioned about any lung biopsy. They mentioned about skin biopsy. So then I look into more references and I find that yes, skin biopsy is also applicable. Like because erythema nodosum things are there, so you can also go for erythema nodosum thing. So lung skin biopsy also applicable. But in between lung biopsy and skin biopsy, of course, lung biopsy. Clear, everyone? So you can treat sarcoidosis. It's an autoimmune multisystem disease, autoimmune disease. We know most of the autoimmune disease can be treated with steroid, right? So here's the treatment, steroid. Wonderful. Are we clear so far up to this? Is it clear so far? Please mention in the comment section so that we can move forward to the next one. All right. I hope you guys are doing well. I hope not so difficult. I tried my best. Respiratory is bit difficult sometimes. Can you see the note section now? Can you see the note section? Like pneumonia, air in the pneumo. Okay. Uh, Quick things. Let's try to be little interactive. I'm also getting tired, so let's ask counter questions. What are the types of pneumothorax you know? What are the types of pneumothorax you know? Okay. Open, starting with that one. Open pneumothorax, yes. Closed pneumothorax, tension pneumothorax, and spontaneous pneumothorax. Quick question. Which one is the most dangerous pneumothorax? Which one is the most dangerous of everything? That is yeah, traumatic it can be. Good. So most dangerous it can be tension pneumothorax, while mediastinal shifting, apex base, trachea, everything shifted, right? So that's the most dangerous one. It's like a one-way valve, very dangerous actually. But there's a MC question they ask, what is the most commonest type of pneumothorax? What is the commonest type of pneumothorax? Answer, most commonest type of pneumothorax is a spontaneous pneumothorax. Spontaneous pneumothorax. It's the commonest one. All right, great. Now, coming to the point about pneumothorax in management, pneumothorax is the air in the pleural spaces, which you need to remove quickly. Actually, if tension pneumothorax, insert the needle directly. If open, closed, and other types, you can give water seal drainage. Are you familiar with the term water seal drainage? I believe at this stage, people are familiar with this term. I mean, I don't have to get into like MBBS and showing water seal and this, that. Okay, so one is you can insert the needle for the tension cases and then the water seal drainage. For the regular cases, if stable patient, you can directly give the water seal drainage. Okay, I hope that's clear. What John Murtagh wants you to know, and here is a picture given already, insertion of the needle in the second space for needle thoracostomy. Remember the term because in the exam it's given as a needle thoracostomy for tension pneumothorax. Now the other John Murtagh cases, you can see less than 25% node symptom observed, drain and drain. Now, it's a lung collapse thing because it's all will be pushed in one side. So if you see less than 25% lung collapse, no symptom, you actually can observe. You don't need to do anything. You just observe and hospitalize the patient actually. But if it is any symptoms is presenting, symptoms like what? Like a breathlessness or a exertion, chest symptoms. In that case, even if it is less than 25% collapse, because patient is symptomatic, you will go for drain. And of course, 25 or more than 25, definitely chest drain or water cell drain is same thing. Is it clear, everyone, or you want to have a look on that management again? Less than 25, um, asymptomatic, less than 25, symptomatic, and more than 25. Okay, more than 25, anything, symptomatic, asymptomatic, chest drain. So always chest drain, except less than 25% and asymptomatic, you can observe. Only one case you can observe. All right. Here is a thing in a nutshell. all the pneumothorax you can read from my note would be more than enough, okay, because everything is given nicely here. So pneumothorax, normally the presentation is breathing problem. Sometimes along with asthma, we also think, okay, it could be pneumothorax because presentation can be as a breathlessness. Now, when you put the stethoscope, how do you understand? It can be most cases either left or right pneumothorax. So reduce breath sound in one particular side. This is how we got the first clue. Then we start, like, of course, the tapping things. And if you find it hyper resonant, it is a classic pneumothorax. Now, reduced breath sound, but when you tap, it's dull. Now, what it could be? This is exam, very popular exam question, and there can be a trauma incidence. Understand one thing: pneumothorax, hemothorax, all these cases can be present after trial chest or any major car road traffic accident. Is it possible? Definitely. Even all these things together possible? Yes, that's also possible. So you can see here reduced breath sound one side and percussion or dull. Answer is hemothorax. Tested topic in the exam. Now they will ask you basic things. In some cases, tension pneumothorax, what to do. In that case, needle thoracostomy. What does it mean? Insertion of the needle in the second intercostal space. Last page, we show you the picture like this. Needle thoracostomy means insertion of the needle in the second space. Same thing. Regular pneumothorax or open cases, you go for a chest drain, basic chest drain, because your patient is stable. Your patient stable. Okay, and they can also give you a picture of pneumothorax. You can see what finding are you expecting, guys? What finding are you expecting? Trachea shifted and apex a little bit shifted. Actually, that's a possibility. Or and one side lung can be a bit compressed. So this is the radiology finding, but still you can go for a CT scan there. Now, there's another question came. They asked for spatial suggestion. Like they give you scenario of pneumothorax and they will ask you what is the spatial suggestion for this patient. Do you recommend, air travel or underwater driving? For this, no, there'll be extreme lung pressure. You must be realized when you are going up in the air and when the patient plane is going down, there's so many pressure. Even on the air, we can realize. In the lung, you don't really realize, but actually there is a lot of pressure. So avoid um, air traveling for initially for 3 months. Also the diving thing. Okay. And already we learned about the 25%, less than 25% observed if asymptomatic, more than 20% chest strain. These are the maximum things you need to know from a pneumothorax. Is it clear to everyone? These are the maximum thing you need to know from a pneumothorax. Just go through the note and all this 7 different way it can be tested in the exam. I have covered it actually. Okay. Moving forward. Feeling better or getting complicated? I know it's almost at the end. Almost at the end. It will take another maybe, yeah, another 15 minutes. Hopefully, we'll be finishing 15 minutes. Yeah. Okay. Anything else you want me to tell about the pneumothorax, or is that okay? I mean, I'm giving a floor. As I said, clinical features, types of pneumothorax, managements of pneumothorax, radiology of pneumothorax. Yes, these are important. And on those 7 things, including the spatial advice. Yes, okay, good. Let's move. Yes. Okay, thank you. I also wanted to move and finish and go to sleep. Yes. All right. But still, you can drop me messages. I'll be checking them actually. Great. Okay. Page number. Okay, page number is pneumonia. Pneumonia, we are currently at 393 page. 393 page. That is what? That is the pneumonia. Pneumothorax, I think 370 is the page number. Yeah. Thank you. Great. All right. I think I've shown you the cut piece already. One was from the John Murtagh. Anyways, quickly get into the pneumonia. About the pneumonia, it's the infection of the lung, right? We all know about it. In case of pneumonia, we all know it's an infection. And if we just take a little time here. Now, do you remember about one thing in the pathology? So this is normal lung, and this is pneumonia. Five parameters of inflammation. I was trying to tell here something unusual so that you remember. Do you remember the five parameters of inflammation? Like a rubor, tumor, calor, dolor. Right? Another one was a functionation. Okay, my memory looks good. Okay. Okay, rubor means redness. Correct me if I'm wrong. Rubor tumor means, okay, swelling. Anyone from pathology background more. Calor means temperature. Dolor means pain. I'm bringing all from the old memories. Functional is a loss of function. This is, French, I guess. Okay, agreed with those points? Okay, now we'll try to add them. Yes, so rubor tumor. So redness, swelling, temperature, pain, loss of function. Now, can we add them for the pneumonia? So is there redness? Of course, I mean, if you open up the lung, definitely there is a redness you will find. Swelling, of course, there is like inflammation and swelled up. That's why you are struggling. Temperature, is it one of the major common thing for pneumonia? Of course, like high temperature, not only raised temperature, but high temperature. Okay, this is a differentiating point. Someday in surgery, I will teach you atelectasis versus pneumonia. First day after the surgery, like high temperature in case of pneumonias. Dolor means pain, and this one is there pain present in pneumonia? Chest type chest pain? Of course, chest pain is definitely present. Okay, so another tick for loss of function. Yeah, I cannot breathe well. So isn't it like a loss of function? So another tick is here. So is it covering all the major parameters of inflammation? So anything which is related to infection or inflammation supposed to have these five parameters. Correct, guys? If I'm not wrong. Yeah. So you already knew about the some of the clinical features of pneumonia. So the fever, loss of function, this, that, and previously mentioned microbiology typical not needed, but microorganism is needed. Have you heard about the big three? This name, yes, streptopneumonia, mycoplasma, and the chlamydia. Big three. Against these three, there is vaccinations available as well. By the way, all right. So even if you take up the spleen sometime, again these three you need to give the vaccines actually. Okay, so again, very important this thing, but there are other multiple microorganisms out there that can also take the life by causing pneumonia, by causing the infection. So again, high temperature you should highlight and cough and this, that. Now, one thing, this is about the typical pneumonia. If the clinical symptoms like breathlessness, other cough things are less, only little dry cough and warm, okay, not high temperature. Will you tell this thing as a typical pneumonia or anything else you want to tell? Answer. There's another term. We call it atypical pneumonia, another very popular thing in the MC. So always when you see the question, differentiate it. Is it a typical pneumonia or atypical? Atypical pneumonia, the clinical features are less, but when you do the X-ray, you will be surprised to see, oh my God. Okay, so that's how the atypical pneumonia. So here is the thing, the theme, never ignore a dry cough. Okay, a dry cough. Sometimes the small kids often comes with dry coughs and they cannot tell like their symptom. So never ignore the dry cough. Okay, cool, great. So as we said, when you're going for investigation, you definitely need chest X-ray, definitely need CBC, definitely need blood culture, right? These are the mandatory things for. These are the some of the mandatory things. Great. All right. Now, moving forward, more things. Some diagnostic criteria is given here. You can also highlight here like treatment uh, nowadays for some of the atypicals. You can go for like azithromycin first. Azithromycin for some of the atypicals actually. And treatment according to severity. Um, okay. Before getting into treatment, have you heard about CARB 65 or CORB 65? If you see my pneumonia note, it's already mentioned there actually. So CARB 65 or CORB 65. Um, yeah. So CORB 65. Yeah. So here is the thing. Confusion, hypoxia, R for respiratory rate, B for blood pressure actually. And yeah, 65 is the age actually. Okay. If this is covering, if like a uh, more points, it's a ground for sending the patient to hospital or even the ICU. It depends of the points. At least 3 points, then ICU. Like 2 points, then hospitals. Okay, correct me if I'm wrong. Now, the most important part in the pneumonia, they'll give you a scenario. In the exam, they'll give you scenario. This that. Sometimes they'll ask you to make a diagnosis based on an X-ray, based on a clinical feature. This is one part. Another part, they'll give you a scenario and they will ask you to choose the right antibiotic. So choose the right antibiotic. Um, in that case, you need this particular page. That means the is it a mild? It is a moderate? Is it a severe pneumonia actually? Okay, mild just comes with a small cough, this that you don't find much exertion. Moderate cases of an elderly person and requires hospitalization. I mean, hospitalized patients over 65 patient and saturation a little getting affected, but not much. Okay, so moderate. Yeah. And severe cases, your saturation will be significantly dropping. Severe cases, your saturation is significantly dropping. Some books says 92, some books says below 90 actually. Okay, that's counted as a severe actually. If it is a below 85, I repeat, if it is below 85, then what do you need? Is simple oxygen would be okay in that case? I repeat my question. If below 85, 85 or below 85, is oxygen gonna enough? No, you need intubation or CPAP. In that case, you need intubation or CPAP. 85 or below cases. Okay. Coming here, like a moderate cases, you see moderate cases, benzyl penicillin or ceftriaxone. Last but not the least, severe pneumonia cases, like again ceftriaxone and cefotaxime. These things are often given as a what is the choice of antibiotic directly. So you need to remember this mild, moderate, severe thing. These things are given as a mild, moderate, severe thing. Guideline for severe pneumonia. Okay, so these are some of the parameter, including CARB 65 as well. But you can see the vital parameters. It's a small, you know, tip here. You can see the vital parameter. So for adults, we understand by the vital parameter. In case of kids, vital will be deteriorating. Secondly, spatial word, grunting. Have you ever heard this term? Grunting. So this line often used in pediatric. So they might give you alongside the hemodynamic instability or vitals deteriorating, and grunting. This kind of word will be given for the pediatric cases. Okay, so that's for the pneumonia. Even though we do have a note, let me just show it to you. So in the beginning, pneumonia, neonatal pneumonia we discussed. In short, E. coli, beta hemolytic streptococcus. These are some of the microorganisms actually. Yes. According to age group, microorganism according to the age group. This type of charts are from the RCH guidelines, guys, and like with a box shaped chart. So sometimes you can chart if you feel like if this disease is related to children, you can type like pneumonia and RCH guideline. So you'll find this type of charts. Yeah, RCH is not related to adults mostly. Yeah. As we mentioned, pneumonia is a condition where they will be talking about microorganism. So some of them can be related to some of them. You can have a look. Like a chlamydia can be related to birds, actually, especially. Someone has a bird things at their home can have a pneumonia because of chlamydia, for example. Someone is a burn patient. Later, they can develop pneumonia. Why? Pseudomonas. So it's kind of like that. And here is the thing, CARB 65 or CORB 65, some people say. So 3 point or more is a uh, something for ICU admission, 2 points for hospital admission. Again, same thing, something for something, for the pneumonia. All right. So you can have a look on that one for the pneumonia and this particular mild, moderate, severe gradings are very important. Okay, we are, I think, almost done. The last topic, tuberculosis, typical tuberculosis, nothing much to say, but I think we all know about the classic tuberculosis already. Um, how tuberculosis usually tested in this last topic, guys. So I'll just take 2 minutes and just show you one chart from latent TB. But briefing about tuberculosis, TB can be anywhere in the body, but among them, pulmonary tuberculosis is most common. Is tuberculosis present in Australia? A quick question. Is tuberculosis is present in Australia? The answer is a no. But can it be present? Yes, by immigrants. Immigrants. Now, so often when we go to Australia, how many of you have are already in Australia or been to Australia? Yes. Yeah, Fiji is little late, so I can understand. No problem. No worries, dear. Your hard work will be paid off actually. Okay. Inside Australia or been to Australia for traveling? Okay, so a lot of people I can see that. Guys, those of you who are not in Australia, stay connected with them. It's important. So before going to Australia, was there any X-ray done for you? Special? Yes. Even I remember during COVID time, I had to renew the visa. I was in Australia that time. That time again, I had to, you know, go for this TB test. Yeah. So for them, this like tuberculosis test is crazy important. Maybe one test. Some cases urine test they do, but mostly it's TB test. So it's mostly immigrant. About tuberculosis, we know about it. Low grade temperature. I think you tell me, guys. I mean, low grade temperature, evening rise of temperatures, night sweat. Okay, then cough for more than 2 weeks, right? And later on there will be hemoptysis, right? Weight loss, anorexia, and later there will be Montague's test positive, right? So that's the thing. And is it the confirmatory? Not really. Montague's is not the confirmatory. Montague's known as tuberculin test. So yeah, we'll be finishing. Yeah. Just in 5 minutes. Yes. Usually classes are 2 hour 30 minutes. Some classes can be like 3 hours long, like cardio. Yes. Okay. Let me finish, guys. Actually, yes. So where I was, okay, tuberculin test. So tuberculin test is the initial, then of course following the X-ray. And what is confirmatory? What is the confirmatory one? Confirmatory one is a sputum. Sputum for AFP is the confirmatory. Sputum for AFP is the confirmatory. Okay. Last but not the least, there's the fourth drug that is given for the tuberculosis, right? So there's a 2 month regimen, then there is a 4 month, total 6 month regimen. For the pulmonary tuberculosis, some other tuberculosis regimen can be 9 months as well. Actually, we're not going there. Yeah, RIPE, you can remember. One interesting thing, most of the anti-TB drugs can cause liver problem. Agreed? Hepatotoxicity. right? Or hepatitis, except for some of the like R, I, P, E. Like rifampicin can cause orange color urine. Isoniazid can cause peripheral neuropathy. Pyrazinamide can cause gout. Or azithromycin can cause retinopathy. And one common thing for all of them is a liver problem. Okay, clear everyone? Hepatotoxicity for all, and orange thing for Grifam, isoniazid for PN, pyrazinamide thing for gout, ethambutol for okay. So this is the basic thing actually for and post TB complications things this that out there. But this is something you will not find in the exam except for immigrant coming from India, immigrant coming from Iraq, immigrant come from any Asian countries can be having tuberculosis. This is how they give this one particular question. And there's a last one question they give, which I will show you in the next class. We do have a recall question regarding that. Is this is the last slide of today. After that, you can go to sleep. So you can see TB. Have you ever heard about the latent TB? Have you ever seen your professor using a TB drugs, even though the patient is not confirmed with TB? Have you seen your professor using anti-tubercular drug, but even the patient is not confirmed with tuberculosis, the diagnoses are counted as the latent tuberculosis. Many times they come with fibrosis, many times this, that. My one of friend was about to die. He was in a different medical because of suspected TB, later find almost like a addition obstruction was almost there actually. Thankfully the surgeon took him to the surgery and removed it. Yeah, serious issue. Okay. So latent tuberculosis, as you can see, the quick question is here, latent tuberculosis may require isoniazid for long term. So that is something. Isoniazid, or have you seen giving artemether type of drugs? Yes. So isoniazid, artemether, these particular things can be used in this latent tuberculosis cases. Now, why I'm bringing this? So one is a latent and one is a active. The question in AMC, and which we will see in the Thursday as well, uh, if it is mentioned, you have only symptom cough for um, 18 days, something a question like this, cough for 18 days or 20 days. Will you consider this thing as a symptomatic? Will you consider this thing as a latent TB? That's up to you. Okay. What do you think, guys? I mean, if you remember, there was a lot of campaigning in our Asian countries. If you have cough more than 2 weeks, think about tuberculosis. Now people know about TB, but long back, maybe 20 years back or something like this, campaignings like that. If you have a more than 2 weeks cough, test for tuberculosis. So we'll think this one as active. And what we will do, are we going for an anti-tubercular drug or are you going for sputum? Because tuberculin test already done, and tuberculin test is not showing much thing. Okay, that's how the question was. So in that case, what to do? Yes, it still needed to be tested sputum if there is a minimal sign of tuberculosis. So sputum is the confirmatory. So if you see anything minimal active about TB, go for sputum testing. And yes, of course, tuberculin is not so always specific actually. All right. A quick thing is BCG, maybe many of you, I also took BCG. Is BCG is given in Australia? I mean, those kids are in Australia. Is BCG given to them? Answer, no, it's not given. Great. So, everyone, I hope somewhere, somehow you enjoyed this session. Um, I tried my best to pull it off. It was a little long session than usual. I mean, in terms of uh, the classes. Thank you so much for joining, guys. I think a lot of people already sleepy, but you hopefully you guys enjoyed. And if anyone joined late, these are some of the page numbers. We need John Murtagh during the live classes. And of course, I mean, those of you joined, I think we sent them ebooks and this, that, so asthma, COPD, bronchiectasis, lung cancer, mesothelioma, this, that, pneumonias, and of course, MC handbook and this that. Some of the MCQ numbers for great. Yeah. You guys can leave me question. I mean, if it's about joining this, that, and yeah, this whole week would be very busy for personally for me and my team. Thank you so much, guys. Yeah, we send you, I think already those of you joined, I think we send you ebooks already. Thank you so much, guys. Thank you. Good night. But still, you need to have John Murtagh 8th edition. That's mandatory, actually. Good night, everyone. This is the end of respiratory theory. Look forward to respiratory recall on Thursday. Yes, recording will be posted tomorrow. Yeah, that's the thing. Great. We'll be opening an inquiry zone. If you have a further questions, you can ask me there actually in that particular group. Yeah, John Murtagh 8th, I think we don't have, so you can buy the John Murtagh 8th edition. Thank you so much, guys. Good night. It's a mandatory field to have John Murtagh 8th edition. Great.